Okay, hello everyone. My name is Cameron Best. I'm a pharmacologist, and today I'm going to speak to you about the surprising link between cancer therapy side effects and autoimmune disease. But before I launch into the main body of my presentation, I first want to go through what these two conditions are and how they relate closely to the dysfunction of the immune system. So first of all, cancer is a series of diseases which are characterized by an abnormal rate of cellular growth. And symptoms of cancer arise when these cancerous cells invade and disrupt tissues around the body, causing their destruction, potential organ failure, and even patient death. Normally, before a cell becomes fully cancerous, it undergoes a number of mutations and changes, and these can be picked up by the immune system, and these cells can be destroyed before they become fully cancerous. However, a number of these cells can evade the immune system and therefore go on to cause the cancer. Cancer research recently said that 1 in 3 people in the UK will be affected by cancer at some point in their lifetime, and ultimately 1 in 4 people will succumb to and die as a result of the disease, therefore showing the dire need that we have for a more effective and more successful therapy. Autoimmune disease, on the other hand, is a series of diseases which are characterized by an inappropriate immune response against healthy cells and tissues across the body. And these include diseases such as inflammatory bowel disease, type 1 diabetes, and rheumatoid arthritis. It's interesting to note that we've been able to characterize the symptoms and the role of key immune cells in these diseases, but we don't actually know what causes that initial spark which gives rise to these diseases. And so that's what I want to look at today, how a certain kind of cancer therapy causes side effects which look closely like autoimmune disease, therefore suggesting that there may be a similar mechanism at play in both conditions. So this type of cancer therapy that I want to look at is known as immunotherapies, and these have gained a lot of press in the scientific community over the last few years. To really understand how they work, we have to look at how the immune system functions and how it can become dysregulated in a cancer environment. So as I said, cancer cells undergo a number of changes which allow them to grow and thrive in the body. And these changes are known as the hallmarks of cancer. One of these hallmarks is the ability of the cancer cells to evade the immune system. And they can do this by increasing the production of key regulatory structures on immune cells. A particular kind of structure here is the checkpoint receptor. And these act as a kind of handbrake on the immune cell, hence the image of a car. So by breaking the immune cells, they prevent the immune cells from targeting the cancers and therefore allow the cancers to go on unregulated. These immunotherapies have been so effective and so pioneering because they utilize the body's own inherent immune system and defense kind of mechanism. A particular kind of immunotherapy are the checkpoint inhibitors, and these work by blocking that checkpoint receptors, releasing that handbrake on the immune system, and therefore allowing the immune system to reactivate and potentially overactivate, killing off the cancer cells. So these checkpoint inhibitors have been described to be the most effective immunotherapy that we currently have. And recently, the work by 2 key individuals, James P. Allison and Toshiko Honjo, resulted in them winning the prestigious Nobel Prize for Physiology and Medicine, which was awarded just in December last year. These checkpoint inhibitors, which came from that research, have been used in the treatment of a number of advanced, potentially devastating diseases, including metastatic malignant melanoma, renal cell carcinoma, and a number of different types of lung cancer. In the figure to the right here, we see how effective these checkpoint inhibitors are against the previous standard of care for a number of these conditions, and we see an overall improvement in the survival of patients as a result of these therapies. However, despite in this clinical trial, despite in these clinical trials, we see that while there's a success where 65% of patients typically survive compared to around 55% or so with the previous standard of care, only 13% of patients complete the 3-year course of therapy. And we have to ask why this small proportion of patients actually complete this. So in the same diagram, I've noted how a massive majority of the patients, 99% of them, experience some kind of side effect. And over half of these patients experience severe side effects, which can lead to crippling disability and even death in some patients. These side effects lead to poor adherence to the therapy, as well as discontinuation overall, and the result being that only a few patients actually complete the therapy. So looking more closely at these side effects, it's interesting that they mirror autoimmune disease. And by that I mean that patients who are administered these checkpoint inhibitors as a form of immunotherapy express symptoms that are similar to autoimmune disease, such as rheumatoid arthritis, type 1 diabetes, and inflammatory bowel disease. The patients who experience the side effects looking like rheumatoid arthritis are said to have rheumatic side effects. And these include joint inflammation and pain, destruction to the joint, including cartilage and bone degradation, and that characteristic immune cell infiltration into the joint that we see in rheumatoid arthritis patients. So again, we don't really understand how these side effects emerge following these cancers or following these immunotherapies. And I think it's interesting to note that while there's potentially similar mechanism or similar properties of the side effects to the autoimmune disease symptoms, this can then lead us to understand how these symptoms arise in autoimmune disease. So the first hypothesis that are being proposed for how the cancer immunotherapy side effects arise describes how these cancer immunotherapies reveal underlying asymptomatic and potentially undiagnosed autoimmune disease. So this is logical, where these checkpoint inhibitors cause that reactivation, that acceleration of the immune response, and this can be potentially enough to exacerbate previously asymptomatic disease, causing it to become symptomatic in patients. However, with this hypothesis, we need to take this with a pinch of salt, where patients with the rheumatic side effects, the ones that look like rheumatoid arthritis, don't always have the same characteristic proteins as the patients of rheumatoid arthritis, which suggests that there's potentially other mechanisms at play here. And so the second mechanism, the one that I believe to be the most feasible, if not more interesting, involves these checkpoint inhibitors, these cancer immunotherapies, causing collateral damage to healthy cells which surround the tumour, which then leads to a self-reactive immune response. So to look at this in a bit more detail, these checkpoint inhibitors, as I've said, cause the release of that handbrake of key immune cells, allowing the immune cells to become reactivated against the cancer. A particular kind of immune cell, a T cell, is highly effective in destroying pathogenic structures, such as bacteria, virally infected cells, and the cancer cells that we're looking at today. These T cells release a cocktail of toxic compounds into the environment around the tumour, resulting in the tumour's death. However, within that environment around the tumour, we see healthy cells dotted around. And by collateral damage, I mean these healthy cells are also vulnerable to this toxic cocktail of compounds. And this vulnerability results in their death alongside the tumour cells. These tumour and healthy cells are destroyed and give rise to proteins which are released into the circulation, and these are then picked up by a number of other immune cells called B cells. These B cells are important in generating antibodies, which are used to increase and amplify the immune response against the structures. Because the B cells have been exposed to healthy and tumour cells, these antibodies become primed to target these, resulting in an amplification of the immune response against the cancer, but also causing an immune response against healthy cells, which may then give rise to these side effects that devastate patients of these immunotherapies. So I'd like to propose that these mechanisms involved may be the same ones as involved in driving rheumatoid arthritis and other autoimmune diseases, where instead of targeting the tumour cell, there may be an initial inappropriate response to bacteria or a virus, which then gives rise to collateral damage to cause these self-reactive immune responses. So I looked at how rheumatoid arthritis is modelled in the world of science. And in mice models, what happens is a protein is injected into the mice, and this then gives rise to an antibody-generated immune response. So again, we see that antibodies play a critical role in modelling arthritis symptoms in these mice. therefore supporting this hypothesis that there's the same mechanism involved in the two conditions, the side effects, and in the autoimmune disease. So just to conclude, I've described to you how effective these checkpoint inhibitors have been and how they can potentially give hope to patients with advanced disease who would otherwise have a poor prognosis. However, they give rise to side effects which can lead to crippling disability and even death in some patients. These side effects are similar to rheumatoid arthritis and other autoimmune diseases, which may suggest that while the similarities of the symptoms may suggest that there's potentially same mechanisms involved here. And this then can be used to help develop more and more effective and successful treatments. Therefore, not only helping to treat rheumatoid arthritis, an autoimmune disease, but also helping to manage the symptoms or the side effects following a certain kind of cancer therapy. So not only does this research show that we can treat cancer patients more effectively, but I think this shows the increasingly interdisciplinary nature of the research, where in future research coming up, we're going to be able to treat more and more elusive and complicated diseases, where we're going to have to look further afield, outside of the box, and more laterally to help develop more pioneering therapies, which can help ultimately win researchers that Nobel Prize, the prestigious award, and hopefully help to improve patient outcome. Thank you very much.
So I have one question for Slido. Somebody has asked, what would be the next step in testing or making use of this hypothesis?
So if I can quickly go back to my slides.
Yeah.
So this mechanism here I was looking at, the critical thing in generating this self-reactive immune response is kind of this area here, where we have the tumor and the healthy cell proteins being released into the circulation, which are then picked up by these B cells. So if we can find a way to target that mechanism by which the B cells pick up the healthy cells, then we can potentially stop that, but keep on allowing the anti-cancer effects from going on. And that might be the next step. So, yeah.
Do you think this research could be useful in treating other diseases that are not cancer, but maybe develop in a similar way?
Yeah, potentially. I mean, the heart of it is looking at these autoimmune diseases, and there's just so many of them that plague different people. And a lot of them we don't really understand at all. So this kind of model could be used to look at how other diseases emerge. And I think it's, if nothing else, it just shows that one disease like cancer may come, or one disease like autoimmune disease, sorry, may be informed, that the mechanisms which give rise to that may be informed by other diseases. And so there's this increasingly interdisciplinary approach with research as a whole, I think. So I think that the key idea is just to look further afield outside of that kind of conventional approach.
I had a question. So I was thinking for a brief moment, and I'm a molecular biologist originally, right? So I'm totally on board with this type of research.
I'm also sure.
Because one way to say my sound, make me sound not like that. So I was thinking about how if you've got someone who has cancer, and you're saying, oh, you're sort of really interestingly weird because of the drugs that we've given you, can we come and study you? does that pose ethical problems? And then my second question that came up from that was actually, was any of the research on this done in people, or is it all in tissue samples in petri dishes in labs?
Well, actually, most of the research I carried out was from clinical trials. So it was from patient data. And I think a lot of the cancer, I can't speak for all of them, but I think a lot of the cancer patients are so troubled by these symptoms and these side effects that they are willing to contribute all they can to help the development of more effective therapies to alleviate the suffering of others. But yeah, all of the data has come from clinical trials, and I think that's analysing that data is just a small part of it. There's going to be so much more information coming from other aspects of the research.
So I have one more question for Slido. Somebody has asked, you mentioned the need to look outside the box. What fields would be the most beneficial to look at in this case?
I think within the kind of area I'm in, pharmacology, there are, I think, many different applications of this, but I'm sure there's a lot of bright people here who can help me out and think of more and more ways that we can use this kind of model of looking outside of the box. And yeah.